The purpose of this talk is to bring out a couple of the more gnarly, interesting topics that are up in the interface right now between practice and research. And exactly the way this particular set of issues came to my attention is that the Journal of Alternative and Complementary Medicine, we all know that one, it's recently had a change of editor. The editor is now someone called John Weeks, who had a blog for years called The Integrator, and is a really interesting thinker on what's going on in the interface between policy and practice and research. And so his vision for the journal is to make it much more practitioner-facing, publisher-facing, less hoity-toity, ivory tower academic, and more really of interest to practitioners. So it was my intention to talk about some issues that came up. A woman called Dr. Rosa Schneier and I are co-editing a special issue that's coming up, and the special issue is about this thing that's starting to happen where practitioners and researchers of quote-unquote alternative medicine systems like Ayurveda and Chinese medicine and homeopathy are trying to validate what we do. We're trying to make some thing of it that's officially real, to say, oh, well, you know, when you look at people's tongues, I did a study like this actually, when we photograph the tongues of pregnant women, maybe there will be some characteristic that separates the ones who are going to have good outcomes from bad outcomes. We actually had a bad outcome of that study. It's the only, it's hard to imagine how you could have an adverse event in a study photographing women's tongues, but we did because somebody fell off a stool at 26 weeks pregnant, which is not the time you want somebody to fall off a stool. So she had to be transported by ambulance the 50 feet from the office to the hospital. And she was fine, everything was fine. We followed her in the computer until the baby was born, and that story was perfect. But, you know, my heart hasn't really recovered yet. So watch out, research can be more exciting than you planned for. But that's it's very close to my heart, this idea of trying to find something real. So they now have the more with the photographs and analyzing the color of the tongue and how many pixels of blue do you have before it's blood stasis, and you know, there's the pulse waveometer and all these ways of trying to validate what we do and make it real. And what's behind all that? It's when we talk to the skeptics, right? It makes us insecure because they ask probing questions that make it sound like what we do is stupid, and we want to say, no, it's really scientific and real. There's the original title for this, which I'm glad we changed, is Acupuncture Research Protocols Are They Complete Rubbish? Because if you want to prove that acupuncture doesn't do anything, one of the best ways to prove that is by giving a bunch of people the same acupuncture points and asking the question, did they get better or not? Of course they did, because the whole thing of what we do is to treat people as they actually present in the moment. So the summary and discussion of the main epistemic issues, right? Epistemology being how do we make knowledge? What are the rules around what's knowledge and what's garbage, right? Issues regarding standardizing our practice, because they keep trying to research it as though it's a drug that you give people. So I kind of want to help us to feel a little stronger on our feet when talking with those skeptics who are saying, well, how can you double blind for acupuncture if you know, things like that. And then also to inform our own reading of the research, to see, you know, a little bit how the sausage is made and what are the areas in which a particular study that acupuncture stinks might be weak, or a particular area that says acupuncture is the best thing since sliced bread might be weak, right? Because you don't actually do well to proudly hand a study to a doctor that doesn't that says we're good, but hasn't gone about saying it in a clever way. So the 4 issues where I think there's really interesting work going on right now that I've been made aware of by studying up for this issue, the idea of standardizing our protocols. I have very strong opinions about this, as you'll see. Point specificity, right? Like as stupid as it already was to give everybody the same acupuncture points, it's now been proven to be even stupider than that, because there's a lot of work on what do we mean by the point? Do we mean the area? Do we mean exact? Is it like a magic elevator button that you press? Is that what's happening with, you know? Surely there's a more intelligent discussion of that to have. Then this idea of inter-rater reliability with the tongues, the pulses, or the total diagnosis, you know, it's embarrassing how bad our inter-rater reliability is. So even in that tongue study, although we had to close it early, we got enough data to establish for sure that practitioners rating the tongues would not be reliable between them. That I would say it was this, you would say it was that, and that's what we mean by inter-rater reliability. And then meaning effects. So this is our beloved Ted Kapchuk is doing all this interesting research into, again, sort of how the sausage is made in the brain, where having the experience of having an acupuncture treatment seems to be inherently a healing thing to do, right? In a way, that's good news. That our placebo effect is better than a lot of drugs, right? If you have fake acupuncture, there are a lot of, like for IBS, we do fake acupuncture is so much better than everything else that's available. It's nuts that they don't say, well, just go to an acupuncturist. And I mean, so if people were thinking rationally about acupuncture, which they're not, it would already be standard of care for an awful lot of things. So to be able to have those conversations a little more confidently with skeptics is a big part of why I'm doing this. So let's talk about standardization. So is anyone familiar with this study? You must have seen this one, Sarah. It's one of my most hated studies ever. It was, you know, physician-run study of acupuncture for labor. It took them, if you read the fine print, it took them forever to recruit for this study, and they had many fewer people than they thought they were. They gave a point protocol that I, never heard of and never would have used in my life for hardly anybody. I've never used this particular combination for any laboring woman. They stimulated the points for 30 minutes before the onset of painful contractions. That was their protocol. And then what did they measure? Did she have an epidural or not? Because sure, anybody who's ever had a baby knows that 30 minutes of acupuncture before the fun starts is plenty to prevent you wanting pain medication, right? That takes care of everything. There was I wrote it with Deborah Betts and Raven Lang, this midwife acupuncturist in the States, and me, and it wasn't you, I didn't know you yet then. Sharon Weisenbach? Anyway, we wrote sort of a tart letter assessing the study design. The design of a recent study is 4 placebo groups too many? Because as far as we were concerned, nobody in that whole study got a meaningful acupuncture exposure. Nobody got acupuncture that you could reasonably expect to change whether she got an epidural or not. I think there are fewer of us enough. We can take some questions. Yeah?
So I'm just not clear at what stage the points were stimulated.
They came in for a labor induction.
Okay.
And so while they were getting their induction, sitting around waiting for induction, they went ahead and gave them some acupuncture, which obviously wasn't going to help at the critical time, right? And so when challenged on this, the author said, oh, well, we chose the points from these previous studies where, and in fact, in those 2 studies, those were studies of acupuncture done in Scandinavia by midwives, where epidural is this last ditch, you know, pain relief with people who aren't coping well. It's not very common there. And so it gets less if the midwives are capably doing acupuncture the whole time, because the birth goes faster and there's less time to want an epidural. But the authors said, well, we're testing the hypothesis as to whether it decreases epidural. There's no indication that anybody involved in the study had any clinical experience of acupuncture in labor. So we forgot to we forgot to make that challenge in our letter, and they wrote back, you know, we said in our in our 80 years of collective experience, we've never given that treatment to anybody. No reason to think would help. And they wrote back, well, we congratulate you on your mean 20 years of experience. Our acupuncturists had 20 years of experience too, but they didn't say they had any experience at all in labor. And our 80 years was experience in labor. So anyway, circumstances, and if they had had experience in labor, they'd have said so, right? Circumstances of treatment were different, right? This was doctors bringing in some weirdo acupuncturists to do this random intervention. And so then because they had such a rigorous study design, you know, they had all this, you know, everybody got the same thing, it was very repeatable. They then literally wrote a press release to all the newspapers, you must have read it, some of you, saying acupuncture is no good for pain in labor. And you can't generalize from that lousy protocol to acupuncture. And you can't generalize from these poor women still got the epidural they were probably already planning to get in this doctor-led unit to it doesn't decrease pain. It might have decreased pain a fair amount, but they still got their epidural because that was what they were planning to do in that context, right? So it's a useless study. And it's to do with this standardization. So for most conditions, it makes way more sense to do what we call a pragmatic trial, which is to find out whether patients should be referred to acupuncture, refer some patients to acupuncture and find out what happens, right? That's what you do. So that's, of course, our wonderful, beloved Hugh McPherson sort of pioneered that in the acupuncture world. He's been talking about that approach since 2004. There's no other sensible approach to the clinical study of acupuncture. If you want to find out what happens to acupuncture patients, send patients to acupuncture and find out what happens to them. So have regular acupuncturists do regular acupuncture in their offices, and then you have what you call external validity. The thing you did to the patient matches what you would really do to the patient in the real world, right? Otherwise, you're making some model pretending that doing these 4 points has something to do with what would happen if a real acupuncturist assessed and treated them. So if you Google scholar search McPherson, you probably have to do McPherson acupuncture pragmatic, but it's a whole corpus of magnificent work backing it. Yep.
Just a question about this. Was the treatment given a kind of fully differentiated, with this idea, is the treatment given a fully differentiated one with different points?
Exactly. So
It's
a
like a
pragmatic
standard,
trial
yeah.
is literally when what you really send somebody to real acupuncture.
In a totally normal way.
Yeah, exactly. Yeah. So a lot of Hugh's studies, literally, they don't even bring them to a different place or something. They literally just randomize people to be sent to an acupuncturist's office or to be sent to an Alexander teacher's office. Right? And which thing are they doing? And that's the real life comparison that you want to make. So the term for that kind of research is comparative effectiveness. And that's how you need to study acupuncture. Yeah?
I'm sorry, so what point before labour would the treatment happen in this model?
Sorry, you're saying if I'm treating a patient during labor and delivery, what would I do differently? So question number 1, is the baby occiput posterior? right? If the baby's head is turned around backwards, then you're in for a rough ride. And you could just turn her on her side, needle, sort of UB60, spleen 6, jiggle her behind, and the baby would sort of roll around. And then you wouldn't have that painful back leg. You wouldn't need to needle urinary bladder points for the back pain because you wouldn't have the back pain, right? So you do it as it presents. My main differential diagnosis if a woman comes to my office who's overdue is there not enough qi and yang to push the baby out? Or is there stagnation, are her knickers in a twist and it's holding the baby in, right? That's your basic, is there not enough yin to dilate or not enough yang to push it out? So without doing that differential diagnosis, Li4 spleen 6 is not the worst treatment in the world, because if there are not enough contractions, it'll make more with Li4, and if there's not enough dilation, it'll have, it's kind of a good catch-all treatment for whoever, whatever, but we could do better if we did what we do, which is differential diagnosis, right? So differential diagnosis is what you get in a pragmatic trial. So when anytime somebody says, well, this study says acupuncture doesn't work, and it's a trial that had a fixed point protocol, you have to say that's not acupuncture. That's not what we do. So there's great utility in all this interesting mechanisms research where they're trying to figure out, well, if we put the needle in the fascia wrap around, but that's fascinating. When we give people acupuncture and stuff changes in their brain, that's fascinating too. That's mechanisms about how acupuncture works. We're not in a place to do the kind of in-between research where we say, does this protocol work better than that protocol? That's not what we would have to treat 20,000 people to compare whether my protocol worked better than your protocol, right? If we're giving everybody the same treatment, because you get crap results when you do that. Yeah?
This comparative effectiveness model, does that work for other modalities as well? So things like Trina, bodywork, gua sha.
Exactly.
If you touch something, you're having a therapeutic effect, and that's the problem with it.
Comparative effectiveness is actually the standard way of doing research for what you call a complex intervention, which is any intervention where you can't exactly specify one active ingredient, which is true for acupuncture, true for massage, true for, psychotherapy. Actually, it's lots of, they spent a lot of time fussing around making manuals for psychotherapy where, at the end of the day, they find out that really the big thing is did they make a good relationship with you? I don't want to go too far out on a limb, but yeah, there's comparative effectiveness research, pragmatic trials, those are your key words, and look for those. It's the wave of the future. It is how we are moving towards studying acupuncture, but we're not there yet. They're like zombie standardized protocol trials still get cranked out, and they're stupid. They don't prove anything. We're not in a place to do efficacy research on acupuncture, and literally this, I think it's not yet, but we'll talk about it in a minute, the trialists collaboration. If you only read one study of acupuncture, that's the one to read, because these titans of acupuncture research got together and put together aggregated all of their data and ran it and proved that for sure acupuncture does have a treatment effect over and above placebo acupuncture, but it's not huge. We'll get to that in a minute. But that trial definitively showed that A, we really do have an effect over and above placebo, and B, the acupuncture placebo is so big that it's not efficient to study acupuncture versus placebo. It doesn't make sense that way. Yep.
I just want to add that sometimes with induction, the most effective treatment is to reassure the person and do points to calm them down.
Right, and points to, but understanding that you need to calm them down and understanding which points to choose and being yourself, those are already important skills that got taught in the clinic and passed down from generation to generation of us, and they shouldn't be overlooked. And that's why the placebo is a dumb way of framing it. So that's our last piece, is the meaning effect. So I'm glad that we'll get to it. Let me keep running though, because I don't want to go late. So under what circumstances might standardization be useful? Doctors like it, right? They like knowing that it's a certain thing. And so as somebody who has labor and delivery and stroke, these are conditions not commonly taught in school. So I do have some, if somebody wants to go out and start a program of doing acupuncture during labor and delivery, I kind of know what they want to do. You know, I don't want them to just run out and do LI4 and spleen 6 in everybody. So there's some of that. So to illustrate the first point of doctors like it, the Paulus protocol got us so much business, and still a lot of fertility acupuncturists will be requested, can you treat this patient only with the Paulus protocol, right? Is that still a thing? That's still a thing, right? Yeah, it's don't do any of your stupid diagnosis and treatment according to your superstitious pulses and tongues and whatnot. Just do this protocol that's proved to work, right? But again, the circumstances of the treatment make a huge difference. So my beloved colleague Lee Hollander-Rubin did a really good study looking at her patients who drove across town and 4 hours later got the exact same point. 4 hours later, don't do it. 4 hours later, not a good treatment, way too moving if you're trying to implant. But as they just squirted the stuff in, you know, and you're trying to implant right now, that's a good time to get this protocol. So do this protocol in the same office. Don't do it in a different office across town. Well, that's important, you know, and you wouldn't have known that except that she looked at 400 something of her own patients. My approach to standardization without locking us into point protocols is that's kind of what I did over the course of my study. I didn't invent the idea, but I was very strongly influenced by, this is a great book if you haven't looked at it, it's Charlotte Firth and a bunch of other anthropologists, and they're looking at not just Chinese medicine, but also religion, like Buddhism and Chinese legal practice, all of which were highly developed in China because, newsflash, it was a highly sophisticated civilization, right? We're not the only, so thinking of ourselves as a highly sophisticated civilization in the world. So their idea about cases is that in a case study, the transmission is not just, like if I read a case study about the use of guizhotong to treat a skin rash, it's not just, the information is not just, oh, guizhotong is good for skin rashes, right? That would be a bad inference on my part. The correct way to read a case like that would be, how did the doctor know that guizhotong was right for this skin rash, right? And it's because he talked to the person and her tongue was pale and she had symptoms of yang floating up and her skin was moist even though it was winter, right? He could see that her yin and her wei weren't in balance, and therefore guizhotong was the right. So you like take the person by the hand and walk them through your thinking process. That is how cases work. That is how we transmit knowledge in Chinese medicine. So Ted Kapchick sums it up really nicely in a foreword he did for a book I read. The unit of knowledge transmission in Chinese medicine traditionally has been the single case, right? You go, this is how I thought about this case. And that teaches your students, versus Western medicine where the unit of knowledge transmission is the study, right? So the how to work through a problem, also used in Chinese law and Chan Buddhism, which is the ancestor of Zen Buddhism. So the word for case in Chinese is gong'an, which in Japanese is koan, right? So that's that the case is a koan that you think about. And I remember early in my training taking a class with this, venerable, wonderful old Shanghan Lun scholar teacher, and he said he put a list of all of the patients who hadn't gotten better, all of his patients where he hadn't helped them, over his sink so he would see it when he washed his hands. And I thought, crap, his list fits over his sink, mine would be one. Where's the phone book? Let me look around. But I just thought that was so that those individuals would continue in his mind as koans to keep him thinking until he got it, which I just thought was magical. So I'm not sure there's any overlap between who was at my stroke thing yesterday, but this is my idea for a standard protocol for treating stroke. Not that you standardize the actions, but that you standardize the thinking process. So is the stroke still happening, right? Is there still deoxygenated cells dying off in the brain right now? If so, raise the chi urgently, right? Is the patient in pain or in distress? If so, take care of that. We know how to take care of that. I can't tell you what points to use because I don't know what kind of distress the patient is in, but you've been to acupuncture school. I trust that you can manage whatever. Patient might be agitated, might have shoulder pain, but whatever it is, manage it, right? Because you're not going to get a treatment effect until you've managed any distress. Then you have to look at their chi machine. Are they constipated, which they often are they incontinent, right? If the chi machine is not running correctly, then you have to do whatever you have to do, including fixing constitutional imbalance, right? If there's not enough yin, they're stuck shut. If not enough yang. And then can they talk and swallow? That's more important. Everyone wants to start in with these guys because they read them and that's the one thing they learned in school about how to treat. Well, if I can't speak or swallow, the hell with that, right? Like, you need to treat my person. And similarly, if I can't balance, you don't want to give me back my leg strength yet, right? You get your balance right first and then you can have some leg strength, mister, right? So you need to recover literally from the inside out from a stroke. And then, are they likely to be able to walk? If so, work really hard on the walking. Are they likely to be able to use their, if it's really like there are signs that tell you the arm is just not going to come back, and if that's so, then you try really hard a few times, and if you can get a little twiddle in the fingers, keep going for it, and if you don't, then just use your energy on something else, because there's always plenty to treat in a stroke. So that's just so the manual as a way of thinking through things. It's a standard approach, which indeed we already have that, right? Like, first look at the patient as they walk in here, then we even have a standard way of taking the pulse if we were trained well, right? First start with fingers on the thumb, and then press all the way down, and they can't. Like, whatever, you have your habits of how to do things in an orderly way, specifically in order to teach yourself and to teach your students to be orderly. So that's if we're going to have a protocol, and we might want to, like for oncology, right? Those patients are so vulnerable. You don't really want everybody going like, what do I feel like treating today? You might want to have a little bit of sort of orderliness in what they're approaching with those patients. So pros and cons of protocols, so they provide repeatability, which give the docs confidence. And at best, they can transmit positive thinking habits, but you really want to think in terms of teaching thinking habits, not teaching what are the points for that. It makes me bats when, my students in school are like, okay, what's the right point for, because it's a differential diagnosis is the right point almost always. And I absolutely have modular point combinations I use. Like, once I know I want to raise the chi, do 20 and 24, I do it all the time, so I'm just in the habit of that. So I absolutely have points I always use, but they're kind of modular by treatment principle rather than by diagnosis. So repeatability is easily nullified by changing in time and circumstance, right? So you do the same points at a different time and place, and now they were the right points before and they're the wrong points now. And at worst, they engender this kind of lazy thinking or diagnosis-based treatment, right? So we just have to be careful around it. So that's protocols. Any more questions on that? I'm going to keep moving. So are acupuncture points real? So how foolish if we've put all this energy in point protocols and now we find out that acupuncture points don't even exist. So this question is I want to call it the dark underbelly of the trialist collaboration. Because again, the trialist collaboration is one of the best things that's ever happened in the whole wide world. So we don't argue with that. But their conclusion, the total effective acupuncture is experienced by the patient in routine clinical practice are clinically relevant. But an important part of these total effects is not due to issues considered to be crucial by most acupuncturists, such as the correct location of points and depths of needling, right? And that's a pretty bold conclusion to make, but literally they made that conclusion by comparing all of these people who got acupuncture. And again, I should have included a graph with 60% and 40%, but approximately 60% of the effect of an acupuncture treatment they would get anyway if you just stuck the needles in very shallowly into fake points, right? There appears to be a curative effect of just talking to somebody nice and having needles stuck gently in your body. I'm always curious if I'm pretty sure that they always stick them bilaterally. And I was always curious if you just stuck them higgledy-piggledy, if the person's chi would actually get sort of disordered, if there isn't something to the bilaterality of the fake point. Even though they're fake, they're located correctly by, you know what I mean? To me, that's a kind of obvious thing that, I don't know, but they didn't ask me. So several lines of argument suggest that acupuncture, whether real or sham, is associated with more potent placebo or context effects than other interventions. So that's actually speaking to what you were saying about, they get into my office, it smells nice. The chi is good in there, isn't it? It might not be when you first inherited the office from the crooked real estate dealers who had it before, but after you do some good acupuncture in there and burn a lot of moxa, then the chi is nice. But many doctors would feel uncomfortable in providing or referring patients to acupuncture if it were only a potent placebo. Well, there's clearly something wrong with our definition of placebo, because a good chunk of what you get when you take an aspirin for a headache is placebo too, and it just the question needs to be better explored. So we're going to talk about meaning effect in a little while, but this non-specific effect of acupuncture, meaning sham needling, when you do like bad needling, either shallowly or even with fake needling devices where you don't even puncture the body, they still have a clinical meaning effect. So in the trials collaboration, it was between 0.15 and 0.23 standard deviation. So that's about the effect you get when you take an aspirin for a headache. Nobody would argue that taking an aspirin for a headache doesn't work. We all know it works. That's as much as you get from placebo acupuncture. The 60% of the size of the real effect, meaning that even mediocre acupuncture is moderately effective, which if you ever taught school, that even the good students, their patients get more better, but even the less good students, their patients still do all right, don't they? Yep.
Do you think there's any effect to the fact that somebody's allowing themselves to receive something that's painful, and that something inside is letting go, that they're in a very vulnerable position?
Absolutely.
And then they're saying to themselves, it's absolutely fine, but that actually might engender a healing response in itself.
That's such a good point. I hadn't thought to think of it exactly that way, but I think that's a really smart point, right? Because what is pain but chi stagnation? And if you're saying, I'm going to allow this pain to be okay, that's quite a huge shift. I think that's really smart. So, and it makes me think of something that I've always noticed and never had an explanation for, which is that of all my, you know how some patients just respond better to acupuncture than others? I have, in my personal experience, one group of patients that I almost always know. If something particular is in their history, I'm pretty sure they're going to be a very strong responder. Does anyone else have this? It's drug addicts. Anyone who, in my experience, has been in the habit of letting the experience wash over them, it seems to me, that's what I put together in my head. I have no idea what it really is. Maybe it's a endorphin receptor thing, but anyway, my experience is, I remember I had this one, you know, he was fine now, but in his history, he'd been an opioid addict, and he had a knee replacement that was gone wrong. They'd done a bad job of it. It was, you know, banging into his femur, horribly painful. We gave him just linku dabai and some ear needles, and he went from like screaming, like unable to participate meaningfully in therapy at all, to, he said, maybe 3 out of 10 or something. It wasn't like it was painless, but he could do his therapy just fine without vocalizing, right? But it just, all the different, and that's an extraordinary result, right? Like he had reported as a 20 out of 10, so 17 out of 10 pain reduction is pretty good. Yeah, so that there's something to that 60%. It comes from somewhere. It's not meaningless, but it's not, it appears not to come from our differential diagnosis and all of the things that I've just said were incredibly important, right? I mean, I still submit that in labor and delivery, where if the head is wrong and you do positionally fix the head, that's a kind of differential diagnosis that you can't argue with, right? Like there's no amount of meaning effect that's gonna, I don't know. Anyway.
Does, when you put in channel acupuncture in, you're activating the channel city network, if not the actual channels themselves.
Yeah, there's no such thing as not a point, right? Yeah. Which is why it's an antique, outdated, foolish way of doing research to try to do placebo acupuncture, right? You wouldn't do placebo massage. Sorry, they're even non-insertive ones. But again, you're lying back with bilateral sensory stimulation of a novel nature. I just think that we're doing something to the parasympathetic and sympathetic nervous system that's not nothing. And there's this meaning effect, whatever that is. Because the people do really think they're getting acupuncture. So I don't know, I mean, I'm not overly interested in where the meaning effect comes. Well, that's not true. We'll get to it in a minute. So this is an interesting paper by Hélène Langevin, who is now the head of the National Center for Complementary and Integrative Health, right? Huge, first time ever, a complementary health person is in charge of the Complementary Health Center. So I'm very curious to know whether, you know, they're going to break her spirit or she's going to break theirs in terms of what kind of research gets done. But I'm hoping for an improvement. So, but she and Peter Wayne, another great Tai Chi researcher and acupuncture researcher, was that, okay, the problem is, like, what is acupuncture? Is it any procedure that uses acupuncture needles? So it could be Asher points, it could be like motor points over a nerve, or it could be acupuncture points. Or is acupuncture any procedure we perform at acupuncture points, which could be bee venoms or herb injections, it could be TENS, it could be laser, right? We're a little bit sloppy in what we mean by, like, oh, only an acupuncturist can do acupuncture, right? Like it's and we're running into trouble with this legally. So this is a really good paper. I recommend people look at. Again, I say, especially since Lynn is so influential now. So there's this interface of using an acupuncture needle at an acupuncture. Okay, that's really what acupuncture really, really is, right? But their challenge is, like, stop ignoring challenges that, oh, the meridians are hocus pocus, and start responding effectively by considering, like, when I have a headache, can you needle any old point in my foot? So there was a set of German studies where, well, let me make sure I get this right. They used the same set of placebo points for headache, back pain, and knee pain. And the back pain and the knee pain, the treatment proved better than the placebo, but the headache, the placebo way overperformed. The placebo did better for headache than it did for knee pain and back pain. Well, if you were using the same placebo points for everybody to make it credible for knee pain, they were all located pretty low in the body. So it turns out if you take someone with a headache and you bang a bunch of fake needles on their legs, still it appears to draw chi out of their head, right? What other conclusion could you draw than that fake acupuncture on lower body? Yes, so you could have regional specificity, right? And you could even have specificity by Taiyang, Shaoyang, right? Anatomical specificity, right? Like a lot of what we think PC6 does, we now think it does because it hits the median nerve and activates the vagus nerve, you know, like that. Kidney 7 and the tibial nerve. I'm shameless in my use of kidney 7 to, you know, let go of pee and hold on to poop because it's over the tibial nerve, which connects to the sacral nerve, right? That's my go-to. Channel specificity, right? So that's we could have a decent chance with the skeptics on saying that's not about the individual point, it's about where we are on this plane of fascial tissue, because it's quite proven that the fascia, not muscles, not skin, not, you know, bone, no other tissue in the body other than the fascia wraps around the acupuncture needle when you insert it and rotate it. So you could say, the channels are planes of fascial tissue, and statistically, by and large, they are. And then trigger points, right? But we have to be careful about saying, oh, we needle the tender trigger points, because that's dry needling, right? And so are we saying dry needling is, you know, if you ask us, or if you ask me, dry needling trigger points are a part of acupuncture. And that the whole doesn't work without, the part doesn't work very well without the whole. But there are all kinds of ways we could work on clarifying the mechanism of what acupuncture points are and how they do work, right? So beyond this meaning effect or this placebo, you know, we could say this is what these points do, and there is some of that. So if our clinical experience is real, then either these authors say, one of two things has to be true. Either we will find the thing in terms of structures we already understand. We will find the thing it does. Oh, it triggers the median nerve, which triggers the vagus nerve, and then we have a parasympathetic, sympathetic, right? Those are concepts we have already to explain the wonderful effects of acupuncture. Or it will drive new biomedical discoveries. So this paper is all about unanticipated insights into biomedicine from the study of acupuncture. So this is a nice one to talk to skeptics about, because it's stuff that Western medicine didn't know about itself until it started studying acupuncture. So how pain works in the brain, strongly advanced by the studies of acupuncture by Richard Harris and Vitaly Napido, right? So we know way more about how pain works in the brain because of acupuncture. And then how the fascia work. My uncle is like, bless him, he's 94. He's a scientist. He studies what's called physiology. You know, the physiology of the membrane transport across red blood cells at Yale. He sat in on a class with, what's his name, starts with an N, the cataloged all the achievements of Chinese technology, science and technology in China. Needham, he sat in on Needham's class in Princeton once. So he says, I start babbling about the fascia as soon as this word comes out, and he says, well, it takes only 2 pages in the anatomy book. You know, it can't be very important. And I said, well, I think they're finding out it's more important. And that discovery was driven by acupuncture. So integrated reliability, I'll do a little quickly. Adds consistency between examiners. So if I feel a pulse and I think it's slippery and you feel it and you think it's surging, we have failed the integrated reliability test, even if those 2 qualities coexist in a person, which can easily happen. So there's been this steady drumbeat of small studies finding that our IRR stinks because, you know, I think it's wiry and you think it's tight and we haven't assigned our terms right, or because heart and kidney insufficiency versus heart and kidney not kidney, like we're sort of saying the same thing about the same patient, we're just using different, you know, emphasizing different pieces of the pathology. And it might just be a mistake to think of the pulse is this, the tongue is that, because really there are these complex amorphous things that we're using to draw a whole clinical picture, the same way we size people up socially, right? It's not like you are, you know, 40% regretful and 13% resentful, and that is your personality profile. It's like I just have a sense of how you behave around disappointment, right? Like we get each other in order to function effectively, not in order to categorize. So the reason that integrated reliability has come up again is because it's this diagnosis that links to the specific acupuncture points. And the concept of point specificity is a little bit like even researchers we thought were our friends like Claudia Witt are questioning point specificity. So it's like the ground's eroding under our feet a little. So how can we fix it? Well, so training doesn't do that well. Actually, you can't. It isn't really there. So just teaching people to do it better, yeah, it helps a little, but not really. Better statistical analysis. So this paper, this guy, Australian young man, I think, a little on the alpha side. So he thinks he's going to transform the way that Chinese medicine is done. We'll see if he hits the big time or not. So you either will or you won't ever hear of this paper. But he both thinks that we need to use better statistics in a way that I barely understand and don't find that interesting to analyze. But his basic concept is that if we just simplify and modularize our diagnosis, if we have stagnation, cold, and blood deficiency, that's the patient, and we don't need to wrap it up into a whole, liver blood deficiency with you have your organ pathologies. You just kind of modularize everything to simplify it, and therefore you're just kind of making the bullseye bigger, right? So that it's easier to hit. There's some value, like if we're trying to demonstrate that what we do has value, there's some value in that. So for example, I always wonder in treating cancer patients, surely your hot patients and your cold patients are going to respond differently to the same chemotherapeutic agent, different side effects, maybe different dosing protocols, or maybe agent A works for me because I'm cold and damp, and agent B works better for you because you're hot and dry, right? Like there could be, what we learn about people is useful. And if we tidied it up in these neat little packages of the kind that doctors like, they might take us seriously in terms of helping them to do their jobs well in an ideal world. And then there's this other strain of research that's like, outsource the whole thing to machine, right? Pulse machines, tongue machines, photographs of the tongue, analyze the pixels, blah, blah, blah. So that's integrated reliability. And then this last topic, which we still have a little time for, is meaning is the new placebo. We've sort of touched on it a bunch of times. Many clinicians would feel uncomfortable providing a potent placebo. Isn't potent placebo an oxymoron? Like, if it's potent, how can it be a placebo? So there's this idea that placebo effect is different from real effect because placebo effect goes away. Well now, Hugh, as it happens, Hugh McPherson did a great study demonstrating that acupuncture effects persist for a year or even two. So thank you very much. It must not, like whatever a placebo is, we must not be just it. So Ernst's objection to acupuncture is largely based on his assertion that placebo effects don't last. So if we can really undermine that argument, then we will have taken a leg out from under his stool. So I think it's really important to focus on this.
Sorry, so what you mean is if it does last, it's not
If
placebo.
it does last, it's not placebo. Like, or whatever, like even if it's meaning related, it may well last, right? Because let's face it, suppose I go to you for an intake about my digestive trouble, and you say, do you eat a lot of cold foods? And I say, yes, as a matter of fact, I do. Oh my God, how did you know? And you say, yeah, Chinese medicine. And I say, well, do you, whatever. You ask me all these questions that are related to my spleen deficiency. You might not even ever put needles in me, and I will have had new insights about how I'm making myself sick that will make lasting change. So it's just ridiculous to say that meaning, just because it's meaning, it's placebo related, right? So mainstream concepts of medical efficacy exclude important shifts of my experience of being in my body. So like you were saying, to accept that pain is happening, the patient gets in a fight with their pain, and that's what makes the stagnation spiral out of control. So if they accept that pain happens and they don't have to have a heart attack about it, we could be teaching them something really important about how to live their lives without ever having said a word about it. So assuming there's a bright line between placebo and treatment is both inaccurate and also just kind of dumb. There isn't a bright line. There just isn't. So Ted Kapchik, and I promise I'm almost done, broad sense, placebo effects are improvements in patients' symptoms that are attributable to their participation in the therapeutic implant. Well, that's us all over, right? We participate really strongly in our therapeutic encounters, and therefore our patients participate really strongly. That's our secret sauce. So it's really important to say to skeptics, no, we interact with people in a way that's helpful for them. Like, and you can't, it's a complex intervention. So if you want to find out how it works, send me some people and find out how they do. That you're not going to make a successful scale model of it that involves doing a few specific points in a particular place. He's not saying it's all meaning effect, but because he's trying to succeed in Western world, he's not saying anything to the contrary either, right? And he's done an important service, so we can't hate on him by bringing it up and kind of bubbling these questions up to the surface and turning the camera on Western medicine itself. I think I have seen treatments where the meaning, like we've all done this, right? You like try this diagnosis, that diagnosis, oh, it's the Shaoyang, oh my God, and then the patient gets better. You cannot tell me that the meaning content was different between treatment number 3 and treatment number 4. All that was different was I needed better points. So we can rest confident in the fact that there is something there because we've all seen it in the clinic. You get it wrong and then you get it right, it makes a difference. But what if that 60% is related to the meaning? Well, we do that well already. So let's rest on that. So this is the same thing we've said, that research on meaning effects so far suggests that the person feels better, but their blood sugar doesn't change, right? That the blood tests won't be affected by meaning effects. So we need to run, we like look at all these things that acupuncture changes already. So we actually have done this research and much more to show that a bunch of stuff changes. So don't hand me that crap about its only meaning effect, right? It's not just meaning effect. Like, and if it is, explain why the rat's inflammatory markers went down, right? The rat was not getting a big meaning effect from the acupuncture. So it does appear to recruit it powerfully because we do it well. But that's a whole different thing. So these are the references for those previous slides in case you want them. So it's this, in this ritual, and this is my last slide, there's an interaction. Like, I come to your office, you ask me the right questions. You don't ask a whole lot of stupid questions. You ask questions where you're being guided by your understanding of the case. So I go, oh my God, yes I do. Now that you mention it, it is worse in damp weather. I never thought of that, right? And so then there's more meaning to me because you already paid attention to me and you already showed that you understand what's going on. And then you palpate, you say, is it tender right here? And I say, yes, how'd you know, right? Like that's another like handshake. Like, remember when the computers, you're probably too young for this, but when the computers had to like beep, boop, beep, beep, boop, boop, right? It's like that like we get a wider and wider bandwidth as the patient gets it more and more clearly that we're with them. We're on top of our game, we understand where the points are. And if I say, your shoulder hurts, I'm looking for a point over here, it should be terrible. Oh my God, that's it, right? Of course it works better because I told you exactly what I was looking for and then I found it. Of course that works better. And then I do this point and I say, move your shoulder and go, oh, it's so much better. It's like 50% better. And then I go, okay, I'm gonna put in a few more ear, so it's a onion peeling step by step. The treatment evolves as I understand what works for you. So the bandwidth of the treatment just keeps getting bigger and bigger. So this meaning effect gets more and more deeply experientially embedded. So, your average, it's hard to say that to a skeptic on email, but to really have the conversation with them, come to my office, I'll show you, right? It's a self-reinforcing effect. So we're done. Yeah, altogether, point protocols and individual diagnosis are both completely unsupported by the evidence. There is value in creating repeatability through a sequence of actions, not a point prescription. And our sequences of treatment do reinforce meaning and specific effect. So it's not just that there's this 60%, 40% thing happening, it's that they reinforce each other. So a good treatment has more. There we go. Thank you.
Thank you.